Assalamualaikum. Boleh mula kot saya
Boleh
rasa.
mula.
Alright, so everyone can listen can see
Can.
Alright, so I present Solihin, supervised by Dr. Wati. We'll be presenting topic of massive transfusion protocol in HSAH lah. Alright, so MTP is defined as transfusion of 10 unit red cells in 24 hours. Usually, most commonly in situation where there is cardiac surgery, GI bleed, triple A leaking or triple A rupture, trauma cases or obstetric catastrophe lah, like non-cardiac theaters or postpartum hemorrhage lah. But we don't really see in HSAH cardiac surgery, tak ada cardiothoracic department pun kat sini. Alright. It involves selection of appropriate amount and type of blood component. But this massive transfusion can be associated with number of hemostatic and metabolic complication. At the end of the day, at least the goals reach lah to save life, right? So in massive bleeding, once you have a massive loss of blood, it can be associated with trauma triad of death. So when you have loss of blood product in your body, in your circulation, it will lead to coagulopathy, and it cause increase in lactic acid in blood, lead to acidosis, and acidosis will cause decrease of heart performance or heart contractility. Then eventually will lead to hypothermia, decrease coagulation, and furthermore increase coagulopathy. So this is where the MTP disrupts this cycle lah. So for MTP,
sebelum let's just go to this cycle ni. So how does MTP disrupt the cycle? Why not just bagi fluid je? Bagilah saline, BP akan pick up. So why sibuk-sibuk nak bagi blood products to break the cycle?
Sebab kalau kita bagi fluid yang macam crystalloid, macam normal saline tu, dia volume expander je. It's like macam air Milo lah. It's like macam
Milo.
It's like when you bagi air je, dia akan jadi dilutional. Dia just ada volume je, tapi content dalam tu macam very dilute lah, solid dia tak ada. So at the end of the day, you still have to give.
Kalau bagi Milo banyaklah solid. Kau cakap macam Milo tadi.
It's like macam
Apa keyword dia di sini?
Dilutional coagulopathy.
Okay, keyword di sini dilutional coagulopathy. Dan kenapa saline dan sebagainya, Voluven, Housemen dan sebagainya tidak boleh replace blood because oxygen carrying capacity dengan hemostatic potential. The factors yang ada dalam blood tu yang menyebabkan dia special oxygen carrying capacity of the blood and clotting factors yang ada dalam blood tu lah yang menyebabkan dia special compared to say saline, Housemen, Voluven, because benda tu semua just macam yang Sodi cakap lah, dia expand the volume. BP cantik tapi it doesn't help with the shock, perfuse tapi tak ada oksigen kan, sebab in the end the end result tu kita nak suruh oksigen sampai kat peripheries kan. So kalau just bagi, and kita pun tak nak increase the BP unnecessarily, because then kalau ni topik lain lah, tapi macam dia akan dislodge the primary clot, then patient tend to bleed more and lose more blood component kan. Then that's why dia jadi cycle tu. So if you go back to the gambar cycle tu, so patient bleeding, so bila dia bleed, dia lost packed cell, dia lost red blood cells, dia lost coagulation factors, dia lost platelet dan sebagainya. The normal physiological mechanism is to cause vasoconstriction then form primary clot. Tapi bila dah lost benda tu, then you bagi pula fluid banyak kan, volume expander ni bagi banyak, that sudden increase in BP tu akan cause the primary clot tu akan dislodge, patient akan start bleeding again, then dia akan decrease lah factors, platelet semua, then lepas tu dia dapat acidosis because dah jadi anaerobic punya respiration. Bila dah acidosis tu, heart pun tak contract as strongly, So BP low, bila dah hilang blood, heat loss as well, sejuk will worsen the coagulopathy, then cycle. You keep giving fluid, patient akhirnya mati. That's why the teaching now is if patient's bleeding or you dah recognize patient tu in hypovolemic shock class 5 ke, class 4, class 5 tu, you need to start with blood products. Tak payah buang masa bagi fluid. Okay. Itu cerita pasal trauma triad of death ni. This is what the cycle that we want to break or prevent. Okay, carry on. Sorry.
Alright, thank you Dr. Right, so criteria for activation for MTP, kalau ada blood loss more than 150 ml per minute lah, or 1.5 liter in adult. 150 ml per minute ni is like a cup lah. Then in adult, the normal amount of blood is 4.5 to 5 liters lah. And transfusion is a replacement of 50% of circulating volume in less than 3 hours. Alright. So like mentioned just now, dalam trauma triad of death tu, dia aim untuk replace lah blood dengan volume tu. Kita boleh je bagi crystalloid, tapi dia tak ada oxygen carrying capacity, tak boleh nak perfuse an organ je lah. Dia akan cause dilational coagulopathy and increase dia punya tissue swelling lah. So dalam kat blood bank ada blood component which are packed cell, fresh frozen plasma, platelet, cryo dengan whole blood lah. Packed cell usually kita akan guna untuk increase HB. FFP usually kita tengok dekat prothrombin time lah, this coagulopathy. Then platelet is the one that we want to replace platelet, and cryo pun for clotting punya factor lah. So at our blood bank, blood component XFO is always available. We can use it directly. For saline cross mesh, full cross mesh, platelet, FFP and cryoprecipitate, you have to hantar sample and wait there sekali dengan blood box untuk tunggu dia thaw for 30 to 60 minutes lah, depend on blood product you asking for. Right. So in HSAH for MTP protocol, if the patient have a class 3
kalau yang nak bawa kotak blade tu, which one you have to bring along ice dengan which one yang tak perlu ice?
For saline cross mesh, full cross mesh, FFP dengan cryo, that one you need to bring ice. Platelet tak payah bawa ice. Right. Okay, right. So we proceed with MTP protocol. So in hypovolemic shock, we activate MTP bila dia ada 150 ml per minute blood loss, and dia classified as a class 3 to class 4 punya hypovolemic shock lah. It can be assessed clinically like prolonged capillary release time or undetectable urine output dah start kurang, extremity dia pale and cold, lepas tu dia GCS pun dah start dropping. Then if there is a finding that suggestive of bleed such as positive fast scan, ada penetrating mechanism, BP low with tachycardia, can consider untuk activate MTP. Then can anticipate 4 units of red blood count in less than 4 hours. If the patient is hemodynamically unstable, anticipate of ongoing bleed. And patient have a severe thoracic abdomen or long bone trauma or major abdomen or GI or surgical bleed. This one are common lah untuk activate MTP. So if the criteria does not fulfill, we proceed with secondary survey lah. And we may not activate the MTP, may require transfusion of blood component, request macam biasa je. Right? If yes, the primary team or specialist will discuss with blood bank MO or blood bank specialist untuk activate MTP. So once MTP activated, all the blood product will only focuses on one case, on that case. So blood request daripada department lain untuk yang consider tak emergency, dia akan halt for a while lah sampai MTP stand down. Right. So for our job as a houseman, untuk bila MTP ni activated, kita akan assign. Seorang akan jadi runner, seorang akan jadi circulator lah. So runner ni dia akan, as the name suggests, it's runner lah. It's running from between blood bank dekat patient, blood bank to patient untuk ambil blood product tu. Dan circulator ni dia akan isi form, dia akan ambil blood daripada patient, akan transfuse and check blood, ada the blood is right for the correct patient lah. So MTP comes in package. For the first package, we need a sample of one in EDTA tube, the purple tube, stickers and form lah. So the blood bank will give a whole blood saline cross match 4 pint and 4 unit of FFP. Then if still required, they will going to give a second package which require another sample as well with 4 sticker, 4 form, the same whole blood full cross match, 4 unit. They will give 4 unit FFP, 4 unit cryo, and 2 unit platelet. Right. If required for the IBC regime, you don't need a sample. You need 3 form, 3 stickers, and the IBC they will give you cryo, 4 unit FFP, and 2 unit platelet. So once the runner dah sampai dekat blood bank, any blood product yang siap dulu, you ambil and terus pergi transfuse dekat patient. Right? So yeah, this is the flow that I mentioned just now. So HO akan ada circulator and runner, MTP activated, isi form, circulator ambil sampel, isi form, tapi need to isi perfectly lah, need to isi correctly. Sebab dalam havoc ni kadang nervous apa semua, tapi ensure everything is right lah, so that dapat transfuse in the correct way. Then runner akan pergi kat blood bank, tunggu blood product untuk ready. Then runner akan bawa yang mana yang ready dulu. Then circulator akan transfuse blood lah lepas dia check blood tu.
Okay, just nak tambah, nak menekankan apa yang Solihin cakap tadi. Make sure forms are filled in properly, especially patient punya nama, IC, kena check betul-betul. Because in the end, korang yang buat, Housemen yang buat. And macam Solihin cakap, bila dalam kelas kabut, MO jerit, specialist jerit, semua orang jerit-jerit kan. So it can be quite stressful and chaotic lah. Tapi you need to make sure that the forms are filled in properly, because issue with blood products ni, salah form, walaupun salah agent, and end up patient being transfused, mungkin the wrong blood ke apa ke, consequence-nya nanti korang yang kena extend, which is sad lah. Walaupun mungkin korang ni seorang houseman yang sangat bagus dan cemerlang for the last 5.5 posting kan, tiba-tiba ada blood related error kan, nanti kena extend 2 bulan. Tak pasal-pasal. This has happened so just make sure walaupun ditekan orang tu jerit, make sure forms are filled in properly. Jangan ada salah-salah. Ini antara benar. And MTP ni dia sebenarnya dia akan secara automatik lah. One cycle habis, dia akan proses second cycle dan sebagainya. So make sure bila tak perlu, korang kena inform dekat blood bank, kita dah stand down. Kalau tak, dia akan just keep going. Sebab dia macam automated punya proses. Okay, this is something yang biasa kita lupa, nak stand down tu. Especially kalau kita activate kat ED, biasanya kita activate kat ED dan patient GOT tak ada masalah. Tapi kalau activate kat ED, stand down kat ED, then we need to inform blood bank juga. Walaupun kadang-kadang blood bank akan call lah, sebab biasanya blood tak cukup untuk blood product, kadang-kadang tak cukup untuk keep going on. So dia akan call tanya, nak lagi ke? Sebab dia orang tak cukup tu, tak cukup ni. Okay. Tapi make sure form isi betul-betul. Okay. Carry on.
Alright. So in patient that receive massive transfusion, kita expect ada additional effect jugalah. So after we transfuse those blood products, need to measure the prothrombin time, activated prothrombin time, and platelet lah. And after administration of every 5 to 7 unit of red cells. So kenapa kita start MTP? Kenapa kita start Instead, kenapa tak transfuse pack cell je? Sebab dalam patient yang ada case trauma with severe coagulopathy, kita akan transfuse juga FFP dengan platelet which ada coagulation factor lah. Kalau transfuse je HB tu, dia akan jalan HB je, patient akan still kurang factor untuk bagi clotting tu, untuk reduce bleeding tu. Then in cardiac surgery pun, kalau patient yang just transfuse pack cell je, tak transfuse FFP, dia akan ada increased risk of bleeding jugalah, walaupun HB dia naik kau-kau. But then dia punya coagulation factor tu tak ada, still akan ada bleeding jugalah. That's why we transfuse multiple kind of blood product in indicated patient lah, in MTP.
Bang, Solihin, just go back to the previous slide. Macam kau just gloss over pula yang 1:1 ratio ni. Cuba cerita sikit.
So kita transfuse for one FFP in severe trauma patient with coagulopathy. Kita transfuse satu unit FFP, ratio to satu unit platelet, ratio to satu unit cell. So let's say kalau kita transfuse 2 bag platelet, kita transfuse 2 bag FFP.
So kenapa kenapa this ratio 1:1 ya? Apa significance 1:1 ratio? And sambil tu MTP kita ni follow ke 1:1 ratio ni? Tak kan?
Tak.
Sebab the IVC regime pun dah macam pelik kan? Dah lain kan?
Nampak tunggu.
So just go back to yang slide tadi. 1:1 punya ratio ni is apparently lah sort of the most physiological ratio of blood product yang sama dengan macam kita punya blood. Okay, in an ideal situation, you want patient with hemorrhagic shock, you want to transfuse fresh whole blood. Kenapa nak fresh whole blood? Sebab fresh whole blood ni dia masih fresh lah. Dia punya pack cell masih memegang oksigen, dia punya clotting factors masih ada di dalamnya kan, belum denature, platelet semua ada. So it's actual blood lah. So fresh whole blood. Tapi the problem with fresh whole blood ni, it must be less than 5 days old daripada you ambil kan. And unfortunately fresh whole blood ni doesn't store very well lah kan. Kalau awak pergi program derma darah dan sebagainya, takkan nak simpan semua dalam bentuk fresh whole blood, rugilah kan. Sebab nanti, so that's why you separate all your blood product tu into components, pack cell, platelet, FFP, cryo dan sebagainya. So that we can store benda ni untuk jangka masa yang lebih lama. Tapi unfortunately so kalau ideal nak fresh whole blood, kalau fresh whole blood tak ada, the next best thing is giving this blood product in ratio yang paling physiological lah, which is 1:1 kan. So tapi masalahnya benda ni is based on study masa wartime dekat Iraq lah. This all are based on military punya study lah. What they notice masa perang kat Iraq, kena tembak, bila they transfuse 1:1 ratio ni, mortality is lower. So dia kata this is the ideal ratio lah. Tapi masalah benda ni is not everyone percaya dengan evidence ni lah. So it's very difficult and to convince blood bank, bukan kat sini je, everywhere, to go with 1:1 punya ratio. Dia still masih benda yang tradisi, di IVC regime dan sebagainya. Because if you think about it, kalau pakai 1:1 punya ratio ni actually lagi jimat rather than you bagi di IVC regime kan, FP dan banyak blood product. So tapi you minta 1:1 ni mesti tak dapat punya dengan blood bank. Tapi you minta di IVC regime dapat. So in the end, this MTP protocol ni is guided based on local punya guideline dan kebiasaan. That's why dia jadi macam tu lah. If you go tempat lain, mungkin ratio dia lain, mungkin style dia tu lain sikit. Satu lagi, and even kalau pergi tempat yang tak ada MTP, things that you need to keep in mind is bila once you dah start transfuse more than, dah expect to transfuse about 5 pints of packed cell, you need to consider bagi FFP sekali and platelet. Just bear that in mind lah kalau awak pergi mana-mana distrik kan. Rasa dah bagi 4 pints, dekat nak masuk, mungkin expected nak bagi 5 pints, you need to consider FFP and platelet as well lah. Because tak guna bagi packed cell sahaja. You need to replace the coagulation factors as well. Kalau tak, patient will have coagulopathy. Nah? Okay, carry on.
Alright. So after transfusion, kita tengoklah sama ada it works, the resuscitation and for transfusion works ke tak. So kita tengok HB at least naik to 8 with dilution 0.25, platelet is more than 50, PT is less than 1.5, APT is less than 1.5, and fibrinogen more than 1.5 lah.
Terma endpoint resuscitation tu macam sedikit misleading lah. Dia bukan endpoint resuscitation. Endpoint bila you nak stand down MTP. Bukan maksudnya, oh dah sampai these values, kita stop transfusion. Bukan, kita stop MTP tu. Then go back to the normal resuscitation lah. You may need to transfuse blood dan sebagainya kat patient, tapi you also need to stop the cycle of MTP tu lah. Bila dah sampai this value, stop MTP, stand down, resuscitate macam biasa. Patient may need to go to surgery, may still need transfusion of blood product, tapi stand down lah, so that tadi macam yang Solihin cakapkan, case-case yang tidak diberi priority masuk balik, berjalan balik macam biasa lah. So gitulah. This is important, kena ada endpoint ni, sebab bila kita nak kata okay, bila kita nak deactivate or nak stand down MTP ni. Okay.
Indication untuk stand down MTP. Alright, tapi bila kita massively transfuse, ada complication jugalah. So since there is ada banyak amount of citrate dalam blood product as anticoagulant, ia akan lead to hypocalcemia, hypomac and worsening yang acidosis dia lah. Sebab dalam blood product tu ada banyak citrate. Then can lead to hypocalcemia, which can lead to cardiac arrhythmia or paresthesia lah. Then can also lead to metabolic alkalosis as well for after massive transfusion. So that's it for my presentation.
Okay, jadi saya nak tambah sikit. Dah halang-halang cerita pasal MTP ni. Saya harap semua orang tahu we have CMEho available in ED itself. So sebelum MTP tu CMEho semua dekat blood bank. Sekarang kita ada CMEho yang memang disimpan dekat ED lah. Okay, so tahu CMEho ada kat ED tu is one thing. The next thing is you need to be responsible lah. Once guna, make sure it's replaced. Kita ada simpan 2 pint CMEho dekat ED yang bila kita boleh guna lah untuk menjimatkan masa kan, patient datang shock, tak payahlah korang lari pergi blood bank nak dapatkan CMEho. CMEho available in ED, tapi once guna, make sure it is replaced, so that in case lah hari tu siapa-siapa yang Jonah on call ke, bekerja ke, back to back, polytrauma with hypovolemic shock, tak adalah lepas tu ada orang mengamuk kata CMEho tidak di-replace. Make sure CMEho tu di-replace. Once guna, make sure do the needful lah. Make sure diisi borang dan sebagainya untuk prosedur dia, saya tak ingat sangat, tapi adalah buku dia, so make sure it is replaced. Jangan nanti tiba-tiba dah balik rumah orang call pula, siapa yang guna CMEho tadi, tak replace dan sebagainya. Walaupun bukan level extension punya kesalahan, tapi mungkin kena bebel juga lah. Okay, so be aware ataupun kepada yang baru-baru tu, in case takutlah kata nak CMEho, larilah pergi blood bank. Tak, kat ED ada 2 pint. Okay,
go back set.
dua pack Safe O. Safe O ni apa benda?
Safe O ni dia blood product from group O sebab group O ni dia universal donor lah. Walaupun nama tapi dekat Malaysia kita pakai O positif sebab majority population Malaysia ni RH positif lah.
Yes.
Dan kita guna walaupun nama dia Safe O tapi it's actually not that safe untuk transfuse to patient. Still kena monitor for transfusion reaction for the patient lah, just in case it happens. Cumanya untuk kalau kita consider risk against benefit, baik kita transfuse Safe O untuk patient yang untuk bagi dia hemodynamically stable dulu. At least it buy some time for us lah before betul-betul blood group untuk patient tu resulted dalam blood bank available for transfusion. That's why we Safe O.
Okay, macam Solihin cakap tadi, O universal donor ni adalah O resus negatif. Tapi we don't have, tak banyak pun donor yang resus negatif. Kalau kat Malaysia ni, among the Indian population, banyak sikit orang with O resus negatif. So kat Sungai Petani ni, be careful sebab some of the Indians resus negatif, O resus negatif. So kat Sungai Petani ni banyak sikit lah resus negatif punya blood. If you go places macam Kelantan yang mana tak ramai orang India, kadang-kadang dalam the whole state tu dia akan ada seorang atau dua orang regular donor resus negatif yang memang boleh di call, dia macam on call all the time lah in case blood bank require resus negative blood, orang ni lah akan dipanggil. Memang dia identify sebab punyalah rare resus negatif ni kalau macam kat tempat macam Kelantan. Kalau kat Sungai Petani ni ramai sikit sebab among the Indian population ada significant portion lah yang resus negatif. So ideal Safe O sebenarnya sepatutnya should be O resus negatif. Tapi because macam Solihin cakap, tak ramai resus negatif donor ni, so kita tak boleh nak keep significant amount of O resus negatif O lah. So what they did is dia pakai yang resus positif O lah. That's why dia jadi Safe O. Sebab Safe O in terms of O is universal donor, it's safe enough lah for most people because most people are resus positif kan. So gitu je lah bendanya. Sebab tu nama dia Safe O tu. Okay, carry on.
So yeah, that's it.
Okay, a few question nak tanya Solihin. Ada extra student?
Ada.
Kalisa? Lepas tu, kat mana you punya form ambil NTP tu?
Form ambil NTP tu dekat blood bank.
Ui, kat blood bank ke? Bukan ada dekat ED ke?
Kat OT ada, kat OT.
Dekat ED ada kan?
Marah Dr. Fiza. Siap lah awak. Dr. Fiza tahu ni, dia cari awak.
Ya. Ya, ada.
Dr. Fiza duk cop orang MTP tu ha. Kesian dia. Kat mana? Orang lain tahu tak kat mana MTP form tu?
Dekat tempat Safe O.
Ada form dia, ada dalam file kalau tak salah saya.
Dia ada folder MTP. Safe O punya form dengan buku ada dekat peti sejuk Safe O tu. MTP dia ada folder dia lah di mana yang Dr. Fiza dah siap-siapkan set MTP dia so that you don't have to be running around cari required form. And dekat form tu dah ada specifically chop dah MTP so that orang lab pun tahu bila borang tu sampai MTP activated. Carilah nanti. Kalau dulu masa sebelum COVID tu benda tu biasa ada kat red zone sebab all the polytrauma in shock semua end up dekat red zone. Tapi now bila kita dah ada respi non-respi ni, saya tak pasti yang kalau kat yellow dia simpan kat mana folder dia tu. Sama juga macam stroke thrombolysis pun dia ada folder dia di mana set-set borang tu sudah disimpan untuk memudahkan kerja korang lah.
So just alert lah dekat mana simpan. Sebabnya tak perlulah pergi blood bank semata-mata nak ambil form tu. Dia memang Dr. Fiza dah sediakan dalam file package 1, package 2. So just grab that form, isi properly, then buat apa yang sepatutnya ikut flow lah. Then macam Solihin cakap tadi, kita punya MTP implication kalau kita wrongly activate. So be careful lah. Sebab nanti kalau kita wrongly activate, katakanlah patient lain yang require urgent pun dia tak akan layan. So memang really indicated baru kita activate. Then kalau dah stand down, kena cepat-cepat inform dekat blood bank ataupun dekat operator untuk announce. Okay, that's all for me. Thank you.
Thank you, Doktor.